Hello, welcome to PH 241. In this lecture, it's going to be straightforward. We're just going to do an intro to the course, talk about the syllabus, and why we're here. And that's it for the week. So before diving into what the course looks like, I wanted to discuss what is the purpose of the course. Why is it a little bit different than perhaps other biostat courses, and why is it important that we know this stuff? So we'll start with that first. Why is it important that we know statistics? I'm assuming most of you are students doing Masters of Public Health. Some of you are PhD students in, say, epidemiology or HPM. Some of you are undergrads. So it's a wide audience, and it's important to understand why it is that this course is required for some of you, and to motivate the kind of stuff that we're going to learn. So the first reason that I think this course is important, that statistics is important in general, that we understand what we're actually doing with these tools, this is kind of the obvious reason. It's that the analyses that you're going to do in your careers actually affect people. Or if you're not doing analyses of data yourselves, then the way that you interpret other people's data analyses as being correct or flawed or whatnot are actually going to affect people. So I'll give you some kind of clear examples of cases where people did really good analyses that actually made a difference. So this first example here is discussing something called the Harvard Medical Practice Study, where in a nutshell, they discovered that a lot of really bad outcomes were happening because of the way that medical care in hospitals was being coordinated, or rather not being coordinated. So people were just making a lot of mistakes. People were administering medicine in ways that were inappropriate, or overdosing or underdosing, not providing appropriate treatment. Just all sorts of mistakes were being made, and there weren't practices and structures in place to prevent that kind of stuff, surprisingly recently. And so there was this study that was published documenting all of that and proposing some solutions. But eventually, really big changes happened. Now we have things like medication administration records. So that's just one example. Another example here, there were some careful studies in the early 2000s of insurance plans, and that directly influenced the way that the ACA, Obamacare, was implemented. Another example was these studies on costs of mental health that directly led to the passage of the Mental Health Parity and Addiction Equality Act. So these are examples of studies that were done well and had actual impacts on legislation or policy. But there's also plenty of examples of studies that are done very poorly, where the statistics was not attended to properly, that had real world harms. So the first is one that you're probably familiar with, the study on the MMR vaccine linking it to autism. And so it was published in The Lancet, which is a pretty big name journal. And it claimed that there's a link between vaccines and autism. Essentially, the paper was of course retracted eventually, but because of this shoddy work, which became accepted as true by a lot of people, it had a huge effect on vaccination rates, outbreaks of measles in various parts of the world. Huge issue. Another pretty popular example is this HRT example. So basically, there's this thought that, well, as women age, hormonal changes occur, and maybe what we should be doing is replacing the hormones that are kind of not being produced naturally anymore. And people thought that this could reduce the risk of stroke and things like that. But it turns out that a lot of that evidence was based on observational analyses, and the people who were getting these hormone replacement treatments tended to be much wealthier and healthier at baseline than the people who weren't. So the benefits were very overstated, and when a high-quality randomized trial was performed later, it kind of said, okay, this is not actually as beneficial as we thought it was. But then there was actually over correction, because since then further studies that have been done very carefully have said actually there may be some benefits in some subgroups. So point being, a lot of people actually abruptly stopped the HRT, and that potentially caused harm. So in actually both of these cases, a sort of like misattention to the subtleties caused harm. And there's another example. Vioxx was a drug that ended up causing a lot of heart attacks. The statistics wasn't quite right. They didn't understand this for a while, and so it was on the market for a lot longer than it really should have been. So overall, the point is that these are just big kind of headline examples. If you do things correctly, you can have a big impact on policy that is beneficial. If you do things incorrectly, don't pay attention to the statistics and these issues, you can actually cause serious harm to people. So it really matters that we understand what we're doing and why we're doing it. And unfortunately, there are rampant misunderstandings of statistics, even in very well cited and published papers, right? Or talk to people who are medical experts in some cases, but have very poor understanding. You'll hear them say things like this, like you always have to check for normality, or linear regression controls for all confounding, or you have to test main effects. Don't use machine learning. Randomized trials are the only way to get at causality. So all of these are often, they're things that you may have heard. They usually come from like correctly identified anxiety, something that you're trying to prevent, but then are actually not fully understanding the entire subtlety of the issue. So end up all actually being total kind of incorrect. And so the point of a course like this is so that you can look at these things and actually in what cases what things should apply, or why it is that somebody says you should check for normality, and why should you need to understand the why of these things. So now if you believe that it's important to be able to do statistics to some extent, or be able to judge other people's analyses, why is it that you can't just go and find someone to do it for you? Why does it have to be you? And unfortunately, you can't really count on other people to check your work. Or maybe you can, but you have to at least have that alarm bell that goes off, that rings, that says, hey, something is wrong here. I don't know whether I should be believing this. I don't know whether I should be doing this analysis that my supervisor told me to do, or whether I need to think twice about this. So you need to at least have that, that alarm system. So why is it that we can't really expect other people to check our work? One reason is that in a field like public health, the accountability loop is super slow and uncertain. So here's kind of two examples. So think about in a like NASA, right? If you're designing a rocket, you design it, you fabricate it, you send it up, and boom, it explodes because you messed something up, right? You measure something in inches when it should have been in centimeters, and you lose everyone on board the rocket. You can definitely bet you're going to get fired because that mistake will be traced down exactly. And it's a matter of probably a year tops, right, from the point that mistake was made to the point that the error happens. So I mean, think of like the Challenger and the Columbia disasters, how quickly it was that those errors were diagnosed, potentially and fixed eventually. So the problem is that in public health we don't have, or medicine in general too, we really don't have that kind of accountability loop. So usually some study gets published. Eventually that study kind of combines with other evidence and works its way into clinical practice. People start using it, and then over years or decades, evidence accumulates for perhaps observational studies that is showing that maybe this thing that we're doing isn't actually the best. Some places stop doing it. Maybe somebody eventually does a randomized trial, but the point is, by the time that we kind of figure out that we're doing the wrong thing, maybe we never figure out that we're doing the wrong thing, those harms have been accumulating probably for decades, and there's no way to really close the accountability loop. Nobody's ever going to get fired for that, basically. Or there's very few examples where you actually have that happen. I mean, the autism case is one where relatively quickly that error was identified, but the harms are still accruing. Even though there was accountability to an extent for the individual who made those false claims. And so you really should not count on this process to kind of like fix mistakes or catch them, because it's not going to happen. So another reason is that really this is Berkeley, right? Like you're training at one of the top schools in the country. We don't have this whole thing about being change makers. So it's like, you're not really going to you're the top, right? People are going to come to you to ask questions. You're not going to have, when you get out there in the real world, you're going to be seen as a leader. You're not actually going to have that many people that you can go to who are considered more expert than you are or something in something. And so it really is going to be up to you in a lot of cases. And you may think, okay, well, what about people who are more senior than me? So something that's interesting about statistics is that it's changed a lot in the past 30, 40 years. And so people who trained in the 80s, people who trained in the 90s even, actually got a much worse education than you are getting right now. So here's this little meme, if you're not familiar with this this meme format. You got like the dude on the left who's like over here who's like a loser, and this guy's like the Chad. And this is basically the situation with stats in 1980 and stats in 2020. So in 1980, people are using all sorts of crazy assumptions that, what was considered big data was like 50 observations, all sorts of approximations that you're using, slow computer software like SAS. And now we have truly huge data, things like electronic health records, and big, large-scale computerized registries. We've got machine learning. We've got interactive data visualizations, Bootstrap, open source software languages like R and Python, the ability to do simulations at scale. So the kinds of stuff that is considered modern practice, people who learned stats 40 years ago don't know anything about. And so it's actually quite difficult to find those kinds of people who will be able to help you, who are more senior than you. So it's really on you. And that can seem a little bit scary. Like I said, it doesn't all have to be on you. You should find statisticians, people like me, for example. But we are sadly few and far between. And if you don't at least know when you need to pick up the phone and call someone and say, hey, I'm kind of out of my element right here, that's a problem. So at least you need to have that alarm system set up.